So continuing then with the connective tissues, starting with cartilage. What's unique about cartilage is it's shown in red. So when you see something in red, okay, you think, maybe a test question, right? Chondrocytes, those are special names of cells that make cartilage. Osteocytes are bone cells. Chondrocytes, chondra is a Latin prefix for cartilage. So chondrocytes make cartilage. So there's no blood vessels or nerves in cartilage. So if you tear cartilage, does it repair really easily? No, oftentimes it requires surgery, right? If you tear an ACL, right, anterior cruciate ligament, that's that dense connective tissue, that also does not repair well, does not have a good blood supply. Cartilage kind of just gets damaged, floats around, and doesn't really come back. That's why when we have wear and tear at joints, it doesn't come back because there's no blood vessels, no nerves. So sometimes we don't know cartilage is damaged until the surrounding tissues around it are not lining up correctly, and then you have wear and tear and pain, right? Because we know we're going to talk about bone. Bone does have a good nerve supply, so when bone on bone is in contact, that hurts. But when there's a cartilage cushion in between and cartilage is being pounded on, that doesn't hurt. So that's the beauty of good cartilage. And if you have good cartilage in your knees and you can run long distances, great for you. I don't have that, so I struggle with trying to stay active because I have bad cartilage. Some people just do. Arthritis is inflammation of the joints and breakdown of cartilage. It just happens in some people. So no blood vessels or nerves, but it's very flexible. It provides a good cushion, and it kind of looks like that fisheye soup we talked about, right? The hyaline cartilage, there's three types. There's hyaline cartilage, fibrocartilage, and elastic cartilage. Hyaline is the most abundant and common. Fibro is really tough. It has extra collagen fibers for toughness. We find those in the intervertebral discs between the vertebrae of our back. So when someone has a slip disc, they're actually looking at the fibrocartilage between the vertebrae that has been damaged. And it also is called the pubic symphysis. It's found where the hips come together in the front. The pubic bone, essentially, what holds the two halves of our hips together in the front is fibrocartilage. And then elastic cartilage is a really flexible cartilage, and that's what we find in the ear. So your ear is real, flimsy and thin. And again, no blood supply or nerves. There is a little bit of nerves in the skin and the tissue around this cartilage. So when you, pierce your ear, it does hurt as you go through there. But the cartilage itself does not have nerves. So it's, it heals really slowly. We can pierce cartilage parts with little bleeding or pain. So these are the cells, the chondrocytes. The black dots here are the chondrocytes of the different cartilages. The fisheye soup is hyaline cartilage. Fibrocartilage, you're going to see these wavy cartilage or collagen fibers between the cells. And elastic cartilage is just a little more flimsy, a lot more cells there. So very flexible is hyaline. Strong and compressible is the fibrocartilage. And the meniscus is where the femur and the tibia sit together. Those are the menisci. We'll look at those in lab. And again, much more flexible is the elastic cartilage. So bone is the most rigid and hard connective tissue. There's two types, spongy bone, compact bone. It has a rich blood supply, and it also has nerves. So bones heal quickly. And that means if you think you have a broken bone, you need to get to the doctor and get it checked out within 2 to 3 days, or it's going to start healing, and it might heal inappropriately, and you'll have a problem that they'll have to go in and do surgery to get it fixed. So it's always a good idea because I have a lot of people ask me questions about, did I break this? I've had students, I've had neighbors, family members, injure themselves. You think it's broken? Most of the time I've been correct, because the one assessment you can use is, can they move it? Because it really hurts. Bone is highly innervated, and it really hurts if it's broken. And if you see a big bump in the middle of the bone, a hard lump where it shouldn't be bending, then you know that's probably broken right there. But sometimes you can get a hematoma. One of our instructors actually injured herself falling while running and has a huge calf, or the front of her shin has a huge swelling over it, but it's squishy. If you touch it, it's squishy, which means there's blood underneath there. So she damaged the bone, released some blood underneath the skin, and it's big and swollen, but it's squishy. and she can step on it. Now, if it was cracked and broken, it would be very painful with stepping on it. Like my son came home and his elbow was just huge, and I thought, oh my gosh, it's broken, you know, and he couldn't, you know, straighten it out, but it was because it was swollen. But did it hurt to move it? No. I had a student come up and say, I think I broke my wrist, but I'm not sure. And I said, can you move your wrist? And she's like, no, I can't. It really hurts. I said, go in, be seen. She came back. It was wrapped up with an ace bandage. She could, you know, an ace bandage didn't stabilize it. And I said, oh, what did they do an x-ray? No, they said they didn't think I needed it. But I still can't bend it. So after a week, maybe you should go back, you know, and just have them look at it, because there was a lump there. It was hard. She went back. They finally did an x-ray. Guess what? It was broken. She came back to class with pins in her wrist because it was broken and it needed to be reset. So rich blood supply, rich nerve supply, you're going to see black and blue, lots of pain if something is broken. But cracks in bone can be deceiving, right? Because those don't necessarily, you know, restrict movement. So you have to be careful. And when my advice to people is always just go get it checked. You know, an x-ray is not horribly expensive. Don't get an MRI. But, you know, an x-ray is not too bad. And it's better to get it checked and know than to go back and have a big issue. Like my daughter's boyfriend right now, he's a football player in high school, and he hurt himself in that big thing in the river. What's the big lake that everybody goes to at the pontoon? There's a big, Crater Lake, there's a big, Ethan, hurt his wrist doing something. And he asked me, do you think it's broken? I said, no, I don't think it's broken. Well, it's cracked, and now he's got a continuous splint that he has to wear for months because it was damaged. Anyway, moving on then, blood, we said, is a connective tissue. You don't think of it as a tissue, but it's the only one with a liquid matrix. So this is truly liquid, like our soup. Red and white blood cells are the cells of that connective tissue, and it can flow through the body. So again, I have things written in red here. It's liquid and it can flow. It's a connective tissue that we call blood. We'll talk more about blood in lab when we get into the cardiovascular system. And then muscle tissue. There's 3 types of muscle. There's skeletal muscle that allows for movement. Smooth muscle contracts and allows our bladder to empty. It generates blood pressure in our blood vessels, moves things through the digestive tract, and there's others that we'll talk about throughout the semester. And then the cardiac muscle tissue is unique, and it's found only in the heart, and it's what squeezes the blood out of our heart to the rest of the body or to the lungs. So what's unique? Again, I put it in red to make life a lot easier for you. It can shorten. When it shortens, it pulls on bones. It contracts when it shortens. It has a rich blood supply and nerves. So if I injure muscle, can it heal itself? Yeah, if I tear a muscle, it will heal, depending on the extent of the tear. If I tore ligaments and tendons, then it's a little slower to heal. But the muscle itself, you know, you get kicked in the leg by a horse or something, you get kicked in the muscle, it's going to hurt, but it will heal a lot quicker than a ligament or tendon would. So it's the only one that's capable of shortening or contracting. So again, I bolded that, indicating that's, you know, critical information to understand. So if I look in a microscope at the 3 types of muscle, in which we'll do this in lab, so I don't expect you to identify it now because this is not lab, just see how different they are. Smooth muscle doesn't have any of those lines that we see in skeletal muscle. It's kind of hard to see in this slide. It's a little small. I can make this bigger. Here it is. So here I can see the vertical lines, the striations of skeletal muscle. I can see cardiac muscle has that too, but smooth muscle does not. That's why it's called smooth muscle. And these cells are kind of tapered and thin. These are branched cells, and these are more cylindrical cells. So we'll talk more about their structure and function in lab, in lecture when you get to muscle. But all you need to know is that it's the only tissue capable of shortening and contracting. And it's not a type of connective tissue. It's in its own category called muscle. So we have epithelial tissue, we have connective tissue with a lot of examples we just talked about, and then we have muscle tissue. And then nervous tissue is the only tissue that can conduct electrical signals. And it's just the flowing of ions that causes what we call electrical signals. It's electrons, which are transferred from one atom to another to form ions, and it's the movement of those ions that causes nervous tissue to generate these impulses. So we find it in the brain, spinal cord, and nerves. We'll talk more about the neuroglia, which are special tiny cells. So this is the big nerve cell here called a neuron, and these tiny little dark cells are supportive cells. So you don't have to know the details about the tissue itself, just its function. So nerve cell, what is its function? To conduct electrical signals. So when we look at an organ then, remember an organ is moving up a level of organization, and it has a variety of tissues. So if I look at the organ, the blood vessel, this might be a, let's see, maybe this is an artery. So multiple tissues make up this organ we call the artery. The inner lining of the artery is simple squamous epithelium. Then there's smooth muscle around that. That's another type of tissue around that artery that allows that artery to contract and propel blood. And then we have this loose packing peanuts on the outside of it. What would that be called? Areolar, or loose connective tissue. So there's 3 different tissue types in this organ, and they're all working together with a specific function. Okay, so some tissues can replace themselves if they get damaged, and some cannot. So epithelial tissue, bone, areolar, dense irregular, blood-forming tissue, those can undergo mitosis and replace themselves. So good thing for that, right? Our skin replaces itself. Bones grow, bones heal, no problem. Some can, but not as well. So dense, regular ligaments and tendons, they can heal to a point. Smooth muscle can recover to a point. But heart muscle, nervous tissue, very little ability to undergo mitosis and repair itself. So if a person has a heart attack, grandpa's out mowing the lawn, gets that intense chest pressure and pain, sits down, relaxes, doesn't tell anybody that he had that intense pressure and pain, or maybe goes and takes a nap and gets up and feels better, some of those cells may have died. When we have intense chest pressure and pain, that means cells are high or have low pH and they're high in lactic acid, not getting the oxygen they need. And if it's a non-essential part of the heart, those cells die and nobody really notices. The person doesn't notice right away. But they might notice, gosh, I'm getting more and more winded when I try to go up the stairs. You know, I'm just not feeling, I just feel tired more. And that's, have you heard when people come into the hospital and say, oh yeah, they said grandpa's had heart attacks before. And that's when we do EKGs, because oftentimes heart attacks that aren't real obvious and people recover at home from them without any interventions, it can cause mild EKG changes, which affects the conduction pathway around the heart and causes their heart to beat in an abnormal way. And that's how we know that there's been damage. There's been a change in the EKG. So cardiac muscle cannot repair itself, nor can nervous tissue. So if a person has, severe nerve damage or stroke, they can't really recover from that and be back at full functional capacity. But can they learn? Can they train other parts of the brain to take over? Definitely. So people that undergo really good therapy, occupational and physical therapy after a stroke, they can get to good functioning again if they stick with it and have a good support system to teach other parts of the brain to take over where the stroke had damaged that part of the brain. But what happens is people don't have good support and nobody does help them, and they just plop them in a nursing home after a stroke and they don't get that care that they need, and then they start the decline. So it's important that people work hard after stroke and not just give up. And sometimes families don't realize that. They're like, oh, dad had a stroke, we're going to do this for him. And then dad doesn't work hard and dad gets worse and worse. So it's important. That's what's really good about occupational and physical therapy, is helping and supporting people to getting back to maximal functioning. It may not be the same as what they were before the stroke, but it hopefully is better than right after the stroke when they're at their worst. So we have research ongoing about the ability of nervous tissue and cardiac muscle tissue to regenerate, but in general, we say that it is not good at undergoing mitosis, and therefore when we damage those cells, they're forever damaged. So tissue repair. This, I can't tell you how many times I talk to my patients about this. They look down, just when I worked on ortho the other day, I was helping a woman in the shower, And she's like, oh, my knee is bleeding, my incision is bleeding, it's going to open up and cause infection. And I had to remind her that when we open, let's say this is my skin, so the skin has a thickness, right? We have the epidermis. Let's say my first finger is the epidermis and the rest is the dermis. This is my skin. I make an incision, I separate the two sides, they do the surgery, close it back up, they sew it up, starting with the dermis, right? They sew it like this, it's all sewed up. How it heals is from the inside out. So it's healing, 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 healed, right? So what happens when it separates at the surface a week after surgery? Should we be afraid that it's all like that on the inside? No. If it's separated on the surface, we can say, oh, we need to maybe do a little better wound care and get those edges together so we don't have a big scar there. But it is healed underneath. But if I see separation 24 hours after surgery, should I be concerned? Definitely, because we can do this and have organs popping out, and that does happen. And you'll learn about that in the nursing program. What do you do? What do you do? Does anybody know? What do you think you do? All of a sudden, someone had abdominal surgery, and now boom, and it's popped out in their abdomen because they were coughing, and that pressure caused them to punch through the abdominal wall, and now they're sticking out. What do you do as a nurse? Before that. So there is that little bit of alone time where your brain has to be engaged saying, what do I do? Wrap them up. What do you think you should put on there? What? Yep, you could do gauze, but that would soak, that would wick a lot of the blood out. What we do to recommend people is you would holler for a CNA and say, get me a bottle of normal saline, and you'd soak a towel and you'd plop it on there. And just keep that soaking wet normal saline towel on there, and then you call your provider. Yeah. You don't have to do anything alone. It's not like you're in a combat hospital, right? Okay, so primary union is when we do an incision. Nice and clean, or you cut yourself slicing tomatoes. It's like, oh man, you got a nice clean incision that you made on your own. So the edges of the wound can be put together. You take a little butterfly Band-Aid or stitch if it's an incision, and that's okay because it's gonna heal. But it may leave a scar. If we cut it a certain direction, you won't have a scar, and we'll talk about that next. But secondary union is when you leave some of your skin on the pavement, right? Road rash, or you fall and really tear a chunk out of your arm. Well, that's not gonna come together nice and clean. And do we want to, and have you ever had this happen where you cut yourself and the doctor's like, I don't want to put those edges together because it's gonna promote infection? What we'll do is we'll wash it out really good and just let it heal, because sometimes we don't want to close in bacteria of a dirty wound. So that's secondary union. So that means it's going to heal like this again. It's going to heal like this, and slowly, if it's separated, slowly the edges are going to come together and fill in, and then now we have a nice closed wound. But that's not ideal. You're going to have more scarring. You're going to have a big white, patch on the surface of the skin where it had to come together to heal. It wasn't pushed together by stitches. So primary union is what we want. Secondary is what we get when we injure ourselves. So this again is how we heal. You can see the healing is happening from the bottom up. So here. So again, you're going to see this at the surface, and then eventually it's completely healed. So we need blood supply for that to happen. So what happens if these capillaries are fried from high blood sugar? The simple squamous cells have broken down from high blood sugar. Can I bring healing chemicals to this open wound if there's no functional capillaries to bring it there? No. So what happens? It gets more infected and more infected. It spreads and it spreads and it spreads. It gets bigger and bigger and bigger until I get into my big artery. Now it's in my blood. And now a patient comes in sick. Remember I told you about the lady who stepped on the needle? She was very sick because she had no functional blood supply to clean that, and it entered her blood. It got deeper and deeper in the tissue till it made her sick everywhere. And all we can do then is just do wound care from the outside, right, to try to get that to heal. But even that's limited, and eventually some people have to lose their toes or even their whole foot, or sometimes their whole lower leg. So sometimes we have to give people a wound vac if it's really bad. When I was in nursing school, I was done with my patients. A couple had discharged. I was just kind of sitting around. hiding in the nurse's station, waiting for clinical to be done. I'll be honest, I was tired. It was the end of the nursing program. You'll get there. But anyway, a nurse says, Jill, come and look at this. There's something really interesting going on in here. I'm like, oh, cool. So I go in there. Oh my gosh. It was a woman who had a wound on the inside of her upper thigh, and she was a heavy lady, so she had a large upper thigh. She had a gaping wound. You know what a video cassette looks like, the old ones, the VHS tapes? You could take a VHS tape and put it in the wound. That's how deep it was, and how wide, and how thick it was. And she's, you know, she's large, so she's leaned back, and it's on the inside of her thigh, and so she can't see what's going on. And I'm like, oh, yeah, that's really interesting. And I'm like, oh my gosh. I mean, that was, you don't ever want that face as a nurse, right? When a patient's sitting there and they're looking and you're going, oh. But it was terrible. It was like a battle wound. I could not, and what it was is she had heart surgery. They did a little incision to take something, to take a artery, or artery out of her leg. They did it a little higher up, and it spread and got super infected. She went home, probably didn't have good care at home to keep her clean, and bacteria from the peri area got down into the wound, got huge. So she had a wound vac, and what they do is they put sponges. When you have a wound that big, they take these coated sponges and they put them down in there, and then they lay a piece of plastic over the top with a tube attached to it, to a little container, and it creates a negative suction, and anytime there's moisture or anything building up in those sponges, it goes through the tube and collects in a little pack that she would wear on her waist. And every 2 days, so she could go home with that kind of a wound. Can you imagine having a wound that big and going home with it? But when they pack it with the sponges, they put that seal over the top and then drain it to this wound vac. She comes in every couple of days, they take the sponges out, they measure, and then eventually what happens is they put less and less sponge in there as the tissue starts to meet. By what type of healing would this wound heal with? Secondary. So by secondary union, eventually fewer and fewer sponges need to go in there and they'll be together. So that's how that happens, and that's the benefit of these wound vacs. So when something is healing, we get something called granulation tissue. Now, you're going to see this in your patients, and when I look at this, when I look for signs of infection, I look for redness and pain and heat around the edge. Do you see redness, pain, or heat on the edge of this wound? I don't. This is a healthy wound. This is called granulation tissue. This is a strawberry red, lots of tiny little blood vessels are forming there. That's good tissue. And a mistake that people make is when they see that, they kill it with harsh soaps and washcloths, and they damage that. So the body is constantly trying to heal, and it can't because we keep damaging it and breaking it down. So when you see this kind of tissue, you don't want to touch it with a washcloth. You just use like a soapy water and squeeze it over the top. Like when people have raw feet from, like we had a guy, his skin broke down and he had raw feet. We don't put a washcloth on that. We put a bunch of pads underneath his feet and we squeezed warm soapy water over. And then we pat dry or even air dry if you can. So you don't want to mess with that. Same thing with scabs. When people pick their scabs, it's removing the body's Band-Aid. The body is closing off this surface. It's working on healing that wound. And when you pick it off, you're just putting yourself back to step one again. And again, promoting infection. Because this scab is a way of sealing the skin, preventing infection. We keep picking it off, we've got more infection. So that's granulation tissue.